Bismillah ar-Rahman ar-Rahim. Hi everyone. On behalf of Saudi Society of Pediatric Dentistry, I welcome Dr. Meenakshi Kher and Dr. Eman Bakhurji. Actually, Saudi Society of Pediatric Dentistry is a non-profit organization founded in 2016 under the auspices of Saudi Commission of Health Specialty. This society is work toward advancement and promotion of oral health of children in the kingdoms of Saudi Arabia. I encourage everyone, every pediatric dentist to subscribe and support our society, because it is work toward oral health in general of population of children. This lecture or this event is registered and recorded, and you can find it in the website, on the web, and also in our YouTube channel. Any question about the lecture can be sent in chat box, and we are try at the end of the lecture to get all the questions and answer it in a matter of time. Today we have Dr. Meenakshi Kher, the first presenter in this webinar. Dr. Meenakshi has pioneered the field of pediatric dental practice in India. She received her master's degree in pediatric dentistry from University of Mumbai 1995 and established Happy Tooth Clinic in Mumbai. Actually, I went through the website of this clinic and it was really marvelous. I love it. It's very luxurious dental clinic center, and I wish to be there. Also, she has become keenly involved in continuous dental education. In 2010, she started Bid Bachella. Actually, Bachella means school in Indian language. So Bid Bachella means dental school, dental pediatric dentistry school, which is a very nice name. And this actually school work for train clinical practice in pediatric dentistry, and it's really served so many pediatric dentists and GPs who are interested in treating pediatric children, pediatric patients. She invited by prestigious international association as guest speaker. Today, Dr. Meenakshi will discuss topic contemporary technique to manage immature permanent teeth, when and why and how of different treatment protocol that support epexogenesis in vital immature permanent teeth. Also, she will talk about regenerative endodontic and the long-term prognosis. Please welcome Dr. Meenakshi, and you have the mic, Doctor.
Thank you so much, Dr. Faisal. I will share my screen. Can you see my screen now? Hello?
Yes, doctor. Yes, we can see it.
Yes, doctor, we can see the screen.
Thank you. Can I? I just want to minimize this button. Yeah, okay. You can see my screen now, right? Good evening, everyone, and it's a pleasure to be here today. Like I was telling Dr. Reem and Dr. Faisal, thank you so much all to the Saudi Arabian Association of Pediatric Dentistry for this invitation. A real pleasure to be speaking with all of you. I will discuss contemporary techniques in to manage the pulp in immature permanent teeth, because like I was just talking to them, I think the immature permanent tooth is an extremely challenging tooth to treat. And whilst all of us are very comfortable with permanent teeth in general, when the tooth is still immature, it poses a unique set of challenges. And what we choose to do as dentists for that tooth pretty much determines what will happen to that tooth for the rest of that tooth life. And of course, we want the tooth to stay with the patient, until the end. So our interventions in an immature permanent tooth become extremely critical. I, like they introduced me, come from the west coast of India, the city of Mumbai, the commercial capital. Perhaps some of you have visited Mumbai. That is our clinic, the Happy Tooth Clinic for Kids. Thank you, Dr. Faisal, for such kind words. In fact, we have, like I was telling them, we have just relocated just day before yesterday. So we are in the midst of all the last minute painting, last brush of paint, coat, and the carpentry. And I literally escaped from there to be with you today. It's a refreshing change, and I'm really happy to be here. This is how it looked. Of course, I would love to share pictures of the new practice, maybe the next time we meet. And of course, post-COVID, all of us are like this, but still with children, we do our best to give them a happy time. Like Dr. Faisal said, in 2010, I established Pedo Pathshala. He was absolutely right. Pathshala is school in Hindi. So it's the pediatric dentistry school. And I was, I've been mentoring dentists and specialist pediatric dentists and dentists from other specialties with a keen interest in pediatric dentistry. It's been a very, very rewarding experience. In fact, I've had a lot of participants from the Middle East as well, especially the UAE. And it's been a lovely journey. In 2019, I wrote the book Contemporary Treatment Techniques in Pediatric Dentistry. It's a step-by-step clinical guide to numerous techniques in pediatric dentistry with about 275 illustrations in color, 58 in black and white. So you do take a look. It's by Springer International Publication. So I'm here today to share my journey of 25 years in managing the pulp in the immature permanent tooth. Like I said, though all of us treat permanent teeth, the immature permanent tooth becomes extremely special. Now, when is the pulp involved in an immature permanent tooth? Either in the anterior, typically post-trauma is when we see a pulpal involvement. And in the posteriors, it would be post a Carious exposure or in a symptomatic tooth. But what is so special about the immature permanent tooth, and why do we need to treat it differently? So when that immature permanent tooth first erupts, by the time it goes from there to there to there to there, erupts fully and the root develops completely, would take anywhere between 3 to 5 years for it to go from here to go all the way to there, would take at least 3 to 5 years. Now, if this tooth suffered a complicated crown fracture with a pulpal exposure, and if I decided to be very traditional, right, and be aggressive, I might go in and remove all the pulp tissue from there. I would then put an apical barrier there. I may decide after obturation to put a post there and prepare this tooth for full coronal coverage, right? What do I have left with in the end? I have this weakened tooth left. Let me translate this into a clinical scenario for you. This is a 9-year-old child. And if I decide to do an epexogenesis in this traumatized tooth, can you see how immature this tooth is? And if I decide to do a post and core and do a full crown. What am I going to be left with? If this is the tooth, that is the immature root there, and that is the site of the exposure. And if I go in, and remember, the tooth is not fully erupted. The clinical crown, this is the clinical crown height. That is all we have as the clinical crown, right? And now I decide to put an apical barrier there after extirpating all the pulp, right? And I do a gutta perca obturation. I place a post there, and then I prep this tooth for full coronal coverage. What I'm left with is this weakened tooth. I'm left with a tooth that has very poor resistance form. Fracture of the remaining tooth structure is highly likely because this tooth is so weak, right? And great chances of a root fracture. And therefore, when you and I treat an immature permanent tooth, it's very, very important to weigh our options, right? To see what choices we have and what are the consequences of each of the choices we make. We must take into account the consequences of each of our treatment options and we must remind ourselves that the immature permanent tooth has considerable capacity to heal after traumatic dental injuries and after carious exposures. There's a great power the tooth has to heal. Now, this is not only in teeth that are pulpily involved, but I would say in anterior teeth, right from a hypoplastic to a hypomineralized tooth, to a discolored tooth, to a fractured tooth that does not have a pulp exposure, to all kinds of pulp exposures, to a missing tooth. Each time we treat an immature permanent tooth, we must remember minimal intervention. We must remember to be conservative. We must remember that the tooth has the potential to regenerate, and we must remember to be additive. Adhesive dentistry and additive dentistry rather than to drill and subtract. In the posteriors, again, be minimally invasive, like in molar incisor hypomineralization when it is milder, and this is on 8-year follow-up. When you use a bioactive filling material like a glass ionomer cement, you are remineralizing the tooth, and the long-term prognosis is excellent. And in molar incisor hypomineralization, full coronal coverage with our traditional steel crowns will stay beautifully. And that is on 4-year follow-up. It will look great. Any pictures from my textbook, any cases that I share, you would see the Springer logo there and the reference there, because I'm supposed to do that every time I share from the book. Now, this is a tooth that was a very odd, unusual traumatic injury in a young permanent tooth. Again, full coronal coverage with a simple hall crown work really, really well. Now, I know that is not about the pulp, but the point I'm making here is in an immature permanent tooth, everything we do should be minimal. We must remember minimum intervention, because the more we save, the more we leave for the future. In that 8-year-old child, God willing, that tooth requires to be in the mouth for another 80 years at least. And we must do less now so that we leave more for the future. And that is the same when we look at pulp therapy. So what are the minimally invasive biological approaches to vital pulp therapy? What, when, why, and how? Typically in an anterior tooth, you would see dental trauma, and that is why you would find that the immature permanent tooth has a pulp exposure, right? Because 20% of all children under the age of 18 suffer from some kind of dental trauma or the other. And most dental traumas occur between the ages of 7 and 15 years of age. And between 7 to 10 years, on an average, is when epexogenesis of that permanent incisor is going on. The tooth is still growing and the root is incomplete. And when a tooth gets injured at that point, that is when the pulp will be injured, epexogenesis will be affected. Now, dental trauma can be a very distressing experience for both the child and the parent. And honestly, it's very, very distressing for you and me, because we have a fixed schedule on that day. We are busy with our routine work, and the dental trauma always comes unannounced, right? It disrupts your schedule, and treatment planning can be extremely confusing. The parent is anxious and hyper, the kid is howling, there's blood everywhere. So it can be really, really difficult, a difficult situation. The first thing is to calm yourself down, then to think and proceed step by step. After managing the initial distress of the accident, the blood and the tears, you have to know what to do, right? And so let me take you step by step through a couple. We could do traumatic dental injuries on another day, but through a couple of instances. Now, typically, crown fractures are simply the most common kinds of dental trauma, and crown fractures could be uncomplicated, or crown fractures could be complicated with a pulpal exposure, right? So what you need to do in a complicated crown fracture, or in any crown fracture first, is to evaluate for tooth mobility, dislocations, injury to the soft tissues, and of course, injury to the adjacent teeth. Follow the IADT guidelines. They are available online. I will not waste time on this right now because it's a little beyond the scope of today's presentation. However, if the tooth fragment is available, we must remember to reattach. There are numerous advantages, extremely conservative, excellent aesthetics, because you're, maintaining right from form, contour, color, surface texture, everything is maintained when you reattach that tooth. Reattachment is a subject I again love and would love to discuss on another day, but we'll quickly move on to the topic at hand. Again, the incisal edge, the advantages of course, fragment reattachment are just too many. So always remember to send the patient back to look for the fragment and get it reattached. It's a great long-term follow-up. Look at this case at 3 years, post-orthodontic treatment and 8-year follow-up, and you can still see how well that tooth is doing and how well that fragment is doing. The rules for fragment reattachment are exactly the same as they are for a class 4 composite resin buildup. No shearing pressures, and other than that, your tooth will look perfectly fine. And if the fragment is not there, again, be minimally invasive and do a simple resin restoration. Now, what about complicated crown fractures? Endodontic treatment, of course, must come first. Even if you found the fragment, the success of the rebonded fragment is obviously secondary to the tooth success, right? So you need the tooth in the long term to survive, and therefore the pulp is very precious and very, very important to us. So let us look at minimally invasive biological approaches to pulp therapy. What is our aim when we are being biological in our approach? Vital pulp therapy procedure, it allows the injured pulp to recover and to function. It ensures continued root growth and root maturation, and it contributes critically to the lifespan of the tooth. What is the procedure? First, you manage or you surgically amputate the pulp tissue that is judged to be inflamed. So it is a judgment call that a clinician makes. The clinician will judge how much of the pulp tissue is inflamed. The remaining tissue is treated with a suitable biocompatible material. This will eliminate the bacteria from the dentine pulp complex and maintain pulp viability. And what we are doing thereby is establishing a suitable environment for epexogenesis. That means for continued root development. What are the 4 prerequisites for successful vital pulp therapy? The first being the remaining pulp is either non-inflamed or capable of healing. What you leave behind should be non-inflamed or it should be capable of healing. Hemorrhage should be controlled properly. A biocompatible or a bioregenerative capping material should be applied, and you want a bacteria-tight seal to be present. How do you go about the technique? Well, there are 3 different ways in which we can go about the technique. The first is a partial pulpotomy, wherein just 2 to 3 millimeters of the coronal pulp is removed. The second is a complete pulpotomy, in which the entire coronal pulp is removed. And the third is an extended pulpotomy, where you go beyond the cervical area of the coronal pulp. And I will take you through cases of all of these. Now, according to the AAPD 2015 guidelines, neither the time between the accident and treatment nor the size of the exposure is critical if the inflamed superficial pulp tissue is amputated to healthy pulp. Okay, but there are some guidelines by which if you go, it will be harder to go wrong and you will get greater success. So I will share those guidelines with you. Some teeth may develop a hypoplastic reaction and inflammation, and the inflammation does remain superficial. Some traumatically exposed pulps may become progressively inflamed and eventually necrotic. So how do you predict the damage, the degree of pulpal damage? What are the decisive factors? Decisive factors are first, the time that has elapsed from the time of trauma, meaning how soon did the child come to you after they fell and had a traumatic dental injury? Was it a week after the injury? Was it, a few hours after the injury? How soon did the child present to you? And secondly, what are the second decisive factor? What is the size of the exposure? Is it a pinpoint exposure? Is it a larger exposure size? When it is a pinpoint exposure and a few hours, and this is a wonderful article by Bernstein et al. In Dental Traumatology 2016. So for those of you who are interested, you must take a look at it. If it is a pinpoint exposure and just a few hours, you could do direct pulp capping. If it is an exposure site up to 4 millimeters and within 9 days, a partial pulpotomy or a Schweck pulpotomy would be ideal. And if it is greater than that, then definitely a complete pulpotomy or a cervical pulpotomy. And now normal, especially in traumatic dental injuries, normal pulp circulation is always the key to success because circulation will ensure future root maturation, right? And therefore, in traumatic dental injuries, if there are root fractures, if there are luxation injuries, this can cause damage to the blood and nerve supply, and that could compromise the eventual prognosis. And that is something you must remember. You have to give the tooth the best chance, but it is something you have to prepare the parent and the child for. Now, let me take you through a journey with a couple of cases because I always feel clinical cases make it easy to understand. This child presented with trauma within 1 hour of the injury and fall. There was a pinpoint exposure. That was the exposure site. This was in 2007. And I decided to do a direct pulp cap. Traumatic dental injuries are emergency procedures. You cannot waste time. So at that time, the only MTA that was available to me was gray MTA, and that is what I used on that day. Okay, I isolated. I cleaned the area with saline. I placed a pellet of sodium hypochlorite on the exposure site, mopped it with saline again, and then placed MTA there as neatly as I could. Okay, and then I placed a bandage of glass ionomer, resin modified glass ionomer there. I did a build-up after a week. The aesthetics is secondary. I did the build-up after 1 week. On 1 year follow-up, you can see a slight gray of the MTA there. This is on 11-year follow-up. I have redone the resin residual build-up here. Just a class 4 build-up, mind you. And this is on 11-year follow-up. That is in 2007. That is in 2018. And if you look carefully, let me go to the previous site again. If you look carefully, you can see how mature the tooth has become here. And it kept up with its contralateral tooth, right? Both teeth have matured equally. So this was a tearing success. It was fantastic. But honestly, if you ask me, I got lucky with this case. And why do I say that? Because what happens in an anterior tooth where there is a pulp exposure is that one of the most important prerequisites for vital pulp therapy is a bacteria-tight seal. And when you do a direct pulp cap, you are not removing any of the superficial exposed pulp tissue. You're just treating it chemically and placing MTA there. Where is my coronal seal? How can I be assured of an excellent coronal seal when I haven't even removed pulp tissue, when I don't have enough depth, right, for a good coronal seal? So often direct pulp cap will tend to fail in the long term. Okay, because once you place the dressing material, that occupies some part of the dentine, right? And then you are putting your coronal seal. So the coronal seal will always get compromised. And the restoration, if it fails, then your bacteria will enter the area. and it will increase the risk of pulp inflammation and of necrosis. Here, of course, I was extremely, like I said, according to me, it's my belief I was extremely lucky. And I wouldn't do direct pulp cap in the anteriors normally. But still, one must consider a direct pulp cap procedure as an emergency procedure. And what is the reason for that? Direct pulp capping is a simple clinical treatment, and it is an excellent emergency procedure. But for good long-term prognosis in the long term, a partial or a coronal pulpotomy should be done. Because with partial and coronal pulpotomy, you are removing some amount of the primary of the pulp tissue. You get more depth there for a good coronal seal, and definitely the survival rates are far more satisfactory. However, if you did a direct, what studies show is if you do a direct pulp cap as an emergency procedure, followed by a partial or full coronal pulpotomy, or if you were to do a full coronal pulpotomy as the first step, either ways, they have similar satisfactory pulp survival rates. So that's something that's really, really good to know. Now, this child presented 30 hours after the trauma and a pinpoint exposure of less than 4 millimeters. We decided to do a partial pulpotomy or a Schweck pulpotomy. Over here, you can see the pulp site, the exposure site, excuse me. This child presented, like I said, 30 hours after the trauma. That was a fairly long time. There's salivary contamination, there's bacteria, there's food debris that has entered the exposure site. So we used a high-speed handpiece cooled under water spray, and a round diamond burr goes straight into the exposure site. You de-roof the pulp, okay, with a burr directly into the exposure site to a depth of 1 to 3 millimeters. An autoclaved burr goes without saying. You do not need to widen the access cavity, just go straight into the exposure site, right? You resect the pulp to 1 to 3 millimeters, irrigate with saline, control the bleeding, but remember, no blood clot. So you want hemostasis, but you do not want a blood clot. And I will explain that further. So compressed with a saline moistened cotton pellet. You don't want a dry pellet because you don't want the pulp to desiccate and you don't want it to be contaminated by dry cotton fibers. So it should be moistened. You control the hemorrhage. So you want hemostasis, but no blood clot because you want the medicament to work on the surface of a healthy pulp tissue. What are the medicaments you will use? Calcium hydroxide or your hydraulic calcium silicates, that's MTA or biodentine. But definitely in your anterior aesthetic zone, biodentine will be a superior material because it definitely stains far lesser than MTA. I will skip these details for short, paucity of time. We have very little time on hand and I want to share a lot with you. You can always go online and read up more about biodentine, but definitely it is superior and it gives an excellent feel. MTA is superb as well, but it will discolor. So we place biodentine there. The moment I place the biodentine, I like to place a layer of resin modified glass ionomer, and then I etch the access cavity. I scrub bonding agent on the dentinal walls. The idea being to block the dentinal tubules because any calcium silicate will have some degree of discoloration. It may be extremely mild, but in the long term, you will see some discoloration and we want to reduce it as much as we can. So we etch the access cavity after protecting the biodentine with a thin layer of RMGI and then scrub bonding agent. And then if the fragment is available to me, like this book, like this case from my book, then I would reattach the fragment, otherwise do a direct composite buildup. That is the immediate post-operative. That is on 2-year follow-up. It's doing very well clinically. And if you look at the before, okay, the mature pulp there, and that is on 2-year follow-up, you can see how mature the pulp has become and how well the reattached fragment is doing. And you can, if you look very carefully, you can also see a fine dentinal bridge forming there. and you can see the apex maturing. Unfortunately, all of these cases have not presented for follow-up for at least 1.5 to 2 years in this COVID period. We haven't called children for regular follow-up if there wasn't an issue with them. So unfortunately, I haven't followed these children up to get even better root maturation. But if it is doing well at 2 years and you're seeing continued root development, it indicates that the pulp is vital and the treatment is successful. Now, this child presented 24 hours after trauma, again, a pinpoint exposure site less than 4 millimeters. So we did a Schweck pulpotomy. And by the way, mind you, Schweck pulpotomy is a permanent treatment modality, because I'm often asked this question. You do not need to re-enter at all. Once you see root maturation, once you see a good apical root growth and root maturation, it means the pulp is healthy and vital. You need not go in again at all. Your coronal seal simply needs to be intact. So again, what a coronal Schweck pulpotomy does is that it preserves the cell-rich coronal pulp tissue. I'm comparing a partial pulpotomy or a Schweck to a complete coronal pulpotomy. The advantages of Schweck pulpotomy are that it preserves the cell-rich coronal pulp tissue, because you're only taking out 3 millimeters of the inflamed pulp tissue, right? And then you irrigate. I'm just going through the steps very quickly again, because this is a procedure you will do most commonly. That is sodium hypochlorite there. Just a pellet of sodium hypochlorite in that area as an antimicrobial. We do not want a blood clot, but we want good hemostasis there. Okay, the coronal pulp, again, like I said, is rich in cells and it is more likely to facilitate healing rather than the radicular pulp that is more fibrous, that is more unicellular with less capacity to heal. Remember, no blood clot, only hemostasis. I've applied biodentine there. Excuse me. After the pulp, dressing material is applied over the blood clot. What I will do is place a layer of RMGI. You can see it even better in this picture. Then I will etch the surface, apply bonding agent, and then put my composite resin restoration. That is the immediate postoperative image. And if you look very carefully, you can see that is the layer of biodentine there. If you see my cursor, this is the, layer of biodentine there. That is the resin modified glass ionomer. And this area here is the composite resin restoration. And then, because we did not find that fragment in this case, I have done a direct composite buildup. The restoration must have a good airtight coronal seal. And this is what we saw on 1 year follow-up. The restoration is doing fantastically well. And that is the root maturation on 1 year follow-up. Can you appreciate that? That is the root maturation there. And this is, of course, 2 years ago. I'm just waiting to see all these children again once this whole COVID issue goes away. That is another long-term follow-up of a Schweck pulpotomy case. Again, this is from my textbook. That is on 5 year follow-up. You can see how amazingly well this tooth has done and how mature the root is looking. Schweck pulpotomy has a prognosis of 94 to 96%. And one of the reasons is also because the fracture line in the anteriors is very, very flat, right? So that allows for salivary cleansing. And it doesn't allow the contamination of bacteria to go penetrate too far beyond the exposure site. And so remember always to try and do a Schweck pulpotomy whenever possible, a bacteria-tight seal, and that is the procedure. Now, the clinical judgment, if you realize, is extremely important to decide, how far you have to go. And apart from these rules, you must remember that the pulp clinical appearance, the amount and the color of the bleeding that you see on the pulp stem, right, are things that you must keep in mind when you decide on what your treatment plan is. This child presented 2 weeks after trauma, and it was a huge exposure site. Can you see a large linear exposure site? far greater than 4 millimeters, more than 9 days. So we decided to do a complete coronal pulpotomy. Over here, similar procedure, control the bleeding, place the MTA or biodentine. Then I like to place resin-modified glass ionomer. Then I etch and apply bonding agent to reduce discoloration, right? And then in this tooth, again from my book, we reattach the fragment. And can you see the beautiful dentinal bridge at the end of 2 years? The great root, further root development, and the lovely dentinal bridge formation. And of course, if the fragment is there, please reattach it. That is on 3-year follow-up. Sometimes you may need to go further inside, as in an extended pulpotomy or a partial pulpectomy. The pulp tissue amputation is extended a little more apically. You're going in a little more. Why? Because you don't like the quality of bleeding there, and you feel that the tooth may be far more inflamed than you want it to. You are unable to control the bleeding. So you go in a little more, and you could call this an extended pulpotomy. In the olden days, we would call it a partial pulpectomy. The pulp tissue amputation is extended a little more apically in these situations, like this case here. And can you see, I've extended a little more apically, and can you see this on 2-year follow-up? I think it's doing so well, right? There's lovely root maturation. You can see apical closure here, and you can see a lovely dentinal bridge form right at the base of where I placed my MTA. And of course, here again, I had reattached the fragment. You can see the fragment reattachment there at the end of 2 years. And here, this is a case where we've again done an extended pulpotomy, and you can see at the end of 2 years, good root maturation. Sometimes you will see pulp canal calcification in these cases. The most important reason for this is because this tooth was traumatized, right? It suffered from a traumatic dental injury. And pulp canal calcification is a common outcome after the less severe luxation injuries and after pulp revascularization in teeth with incomplete root formation. So in immature permanent teeth that suffer from luxation injuries, and where you do you want epexogenesis to happen, often you may see pulp canal calcification. Now, depending on the cells invading the root canal, this calcification could be connective tissue that is forming there. It could be cementum that is deposited there along the root canal walls. In any case, it doesn't matter. In open apices, it could even be bone that has invaded into this area and caused the calcification. But if you see intact PDL, like I'm seeing in this case, that is fantastic. This tooth is a complete success. You have preserved this tooth for a very, very long time instead of getting aggressive and doing more aggressive procedures. The aim of an extended pulpotomy is to ensure a suitable environment for the physiological root development of a traumatized young permanent tooth. The main goal is to avoid the need for an epexification procedure or a regenerative endodontic procedure, which are far more complex. Because when you do an epexification procedure, not only is it complex, but the fact is the root doesn't get any stronger, right? You put an apical barrier there, but the root remains as thin and weak as before. And these teeth are extremely prone to fractures in the long run. So longevity is affected, and that is something you do not want. But what happens if the pulp is necrotic, right? Now, this is an immature permanent tooth with pulp necrosis. Now, immature permanent teeth with pulp necrosis, if you are looking at not doing epexification, which is what I do, I have rarely done an epexification procedure in years now. 2010 was the first time I did a regenerative endodontic procedure in the immature permanent tooth. But what I realized for today's lecture was that this subject in itself is very complex and extremely long. And to push this into today's topic would be not achieving anything, because I would not have been able to explain the philosophy or the technique to you properly. So we'll definitely leave that for another day. I will share a couple of cases like this. Look at this in 2010. This was a hopeless situation where I did a regenerative endodontic procedure. And 5 years later, can you see the root maturation and how beautifully this root has matured? This is another situation where they were really immature roots. And this is at the end of 4 years, a nice long-term follow-up. And this root and these teeth are doing extremely well with regenerative endodontic procedures. But I thought instead of discussing, REP, that is regenerative endodontics, half-heartedly in 10 minutes, I'd rather proceed with a little more about epexogenesis instead in the posteriors. So this whole subject I can cover more effectively, because that will equip you, to tomorrow in your practice to just simply do a better job with immature permanent teeth. Because we must remember, immature permanent teeth are not just our anteriors that have suffered from a traumatic dental injury. They're also our young posterior teeth, where there could be an inadvertent pulp exposure, or where there could be a symptomatic tooth because of a carious lesion, and the tooth becomes symptomatic. Now, these are immature teeth. And how are we, and what am I talking about? Because a lot of you may think, we already know how to deal with this, right? So what's new? But, the philosophy, again, for immature permanent posteriors has changed for treating the pulp. And that's something I wanted to share with you today. Of course, a lot of you may be familiar with it, but I wanted to share this with you. Now, again, the reasons for treating these teeth differently from a mature permanent tooth that has dental caries is that the immature completely erupted. Therefore, it has a very short clinical crown, large pulp spaces, right, and large pulp horns. And lastly, immature roots have open apices. Again, that poses their own set of distinct challenges, right? So when we treat an immature permanent tooth in the posteriors, again, we need to remember to be conservative. We need to remember regeneration. We need to remember minimum intervention. This begins with how we treat a carious lesion in an immature permanent tooth. Because if we treat deep carious lesions in a minimally invasive way, automatically we will reduce pulp exposures. So I will fail in my duty if I do not discuss with you managing a deep carious lesion in an immature permanent tooth. So I will very quickly in the next couple of slides discuss this subject again that's precious to me. The first thing you could do is completely not remove carious tissue at all. Excuse me. That is no removal of carious tissue, as in this case of a child with severe special needs, a child in the autism spectrum, who managed to sit on the dental chair, open his mouth because he was a little older now and he'd been coming to me regularly, and allowed me to actually get inside his mouth and remove the debris with a spoon excavator very gently from this carious lesion. I struck silver diamine fluoride there, and I placed glass ionomer Equia Forte there and high viscosity glass ionomer, and look at the 1-year follow-up, right? That is the 1-year follow-up. You can see further root maturation here. You can see a lovely calcific barrier here. So you can be really minimally invasive even with deep carious lesions. But when we very often treat deep carious lesions in an immature permanent tooth, we must remember to remove carious tissue selectively. In the olden days, at least, we were trained 30 years ago when I became a dentist, we were trained to dig into the carious lesion, remove all the carious tissue, remove all the brown, all the black until you saw white or you saw pink. And if you saw pink, you went into the pulp and you extirpated the pulp. Today, we believe there is no reason to remove all the carious tissue, because carious tissue is perfectly capable of healing, perfectly capable of remineralizing, and therefore we must remove carious tissue selectively. And I have an entire chapter on this topic in my book, because I really, love being minimally invasive, even in primary and permanent teeth. So you remove adequate carious tissue. The two Regeneration rules is you remove adequate carious tissue to place a restoration that has sufficient bulk, and you clean all the carious tissue from the walls. So you have a clean wall and you have a good hermetic seal, right? So you prevent bacteria from entering the carious lesion, and you thereby avoid pulp exposure. Now, Ines and their team have distinguished the carious lesion for you and me, the clinician, with the use of tactile sensation into soft, firm, and hard. But I won't waste too much time on it. The idea being, in a very deep carious lesion, most of your carious tissue is extremely soft, but you must only go to the depth that is enough for you to place a restoration of sufficient bulk. But on the walls, you must clear all the carious tissue so you reach firm dentine. So on the walls, you need to reach firm dentine, but on the floor, you just need adequate depth. Okay, and then a good hermetic seal. This is one example of very deep carious lesion. But of course, this tooth was so bad that I decided I would do full coronal coverage for this tooth, which is often not required, hence the rubber dam. Otherwise, you selectively remove carious tissue. You need not, use a rubber dam for those situations. You just remove the tissue. Here, of course, I did put mineral trioxide aggregate there, placed glass ionomer, and placed full coronal coverage with a stainless steel crown. That was on 2-year follow-up. You can see the premolar erupt and see how well the tooth is doing, how mature these roots are, and how we've managed to prevent pulp treatment completely. And you can see the zone of remineralization there. Another situation of deep carious lesion, that was the tooth. Again, we removed carious tissue from the walls, cleaned the walls, left tissue on the floor. I don't want to dig deeper. If I dig deeper, I will create a pulp exposure that I do not need. Remember, these are all teeth that show no signs, no symptoms of pulp pathology, no signs and symptoms of pulp pathology, right? And then I give it a good coronal seal with a stainless steel crown. That was on immediate follow-up. If you look at this was on 1-year follow-up. Look how healthy the gingiva is, and look at the radiograph doing really well. That was the preoperative, and this is the 1-year follow-up, and see how well the root is maturing, and everything's doing really well. And I've got numerous such situations. Again, you can see a lovely calcific barrier here with glass ionomer and high viscosity glass ionomer, like Equia Forte does very, very well in these situations. You see the calcific barrier. So the advantage is you're preserving dental tissue, you're maintaining pulp health and avoiding pulp exposure, and you're avoiding dental anxiety and stress, both for the patient and of course for the operator. I'll take the last 5 minutes, Dr. Faisal, to discuss with you symptomatic immature permanent teeth. Now, what happens if this posterior tooth becomes symptomatic? The patient comes to you with all signs of irreversible pulpitis, right? If the patient comes to you with severe pain, with prolonged dental pain, right? Or with spontaneous pain, the mother comes and says the child woke up in the night and started crying with pain, right? We've been taught to call this irreversible pulpitis. What does the word irreversible mean? It means that now it is gone. It cannot be reversed. It is dead, right? That's what it means. And we've been taught if there's irreversible pulpitis, you need to go in there and do a pulpectomy and remove all the pulp tissue, correct? Or if there's pain that lingers after you withdraw the stimulus. For all these situations, we have been taught to call this irreversible pulpitis, and we've been taught to do a pulpectomy procedure in these teeth, right? And in nighttime pain. Typically, we would do a root canal treatment, or if it's an immature tooth, we would go there and do an epexogenesis, or then we would extract the tooth, correct? But what we realize today and what science is telling us is that you can do a vital pulp therapy for immature permanent teeth that shows signs of irreversible pulpitis. Why is that? The reason is that when a tooth is diagnosed with irreversible pulpitis, there is if it is an immature tooth, mind you, I'm talking about immature teeth. If an immature tooth is diagnosed with irreversible pulpitis, there is always vital tissue there. There is always vital pulp tissue there, and this tooth has the potential to heal. And therefore, we must not condemn these teeth and term them as irreversibly inflamed, because there is always some vital tissue left in these teeth. And I am a clinician. I am not a researcher. I just use the knowledge that researchers provide in my practice for the benefit of the patient. So I am not just speaking out of clinical experience. I'm speaking out of what evidence is showing me. I've always believed in evidence-based dentistry. And what I'm sharing with you is evidence today, and what I have used in my experience in my practice to great success. So what are the prerequisites for vital pulp therapy in a posterior immature permanent tooth that shows signs and symptoms of irreversible pulpitis? The prerequisites are that the remaining pulp tissue is capable of healing, that hemorrhage is controlled, that you're using a bio-regenerative cement, and you give the tooth a good seal. And current available evidence shows us that when there is lingering pain, even a nighttime episode of pain, you can still do vital pulp therapy. So preoperative decontamination, applying rubber dam, remove the carious tissue, deroof the pulp, irrigate with 2.5% sodium hypochlorite, achieve hemostasis. Okay. Earlier, we would use ferric sulfate. We do not want to do that. That will mask the inflammation. So we will not use ferric sulfate. We will just use moistened cotton pellet, place MTA there on the surface to completely cover the surface. I like to place resin modified glass ionomer. And then, of course, I will give a full coronal coverage with a stainless steel crown. That is on 6-month follow-up. And I will show you other cases that have better long-term follow-up. So in deep carious lesions, they are not unconditionally related to an irreversible pattern of pulpal injury. These are fantastic articles. Taha et al. And Walters, please go through these articles. If I'm not mistaken, Dr. Taha and their whole team actually comes from that region, if I'm not mistaken. So I'm sure a lot of you are familiar with all of this. The rationale is that spontaneous and severe preoperative pain does not always indicate that the pulp is not capable of repair. Remember, the immature pulp is capable of repair. And therefore, we must give it a chance to recover and to heal. And you must look at not going in and removing all of the pulp tissue. Yeah, because pulps may be necrotic at the exposure site. However, pulp tissue in the root canals may be reversibly inflamed. Yeah, and so the advantages of a biologically driven procedure are that pulp tissue is preserved, and therefore you're maintaining the physiological and defensive functions of the pulp. The biological immune response from even a partially retained pulp would improve the treatment outcomes by preventing infection in the periapical area. And the less hard tissue you remove, obviously the less you weaken the tooth, right? And long-term prognosis is always better in a pulpotomized tooth if you compare it to full pulpectomy. So when you compare a pulpotomy to full pulpectomy, there is no doubt that a pulpotomy completely wins over. 100% success of coronal pulpotomies with MTA. Okay, where signs and symptoms indicative of irreversible pulpitis have been reported, 100% success rate. Those are these articles, but I have experienced that in my practice as well. Complete success rate. So please, in immature permanent teeth that are not necrotic, that show signs and symptoms of irreversible pulpitis, where you see bleeding happen, where you can control the hemostasis, where you can give the tooth a good coronal seal. Remember to do a full pulpotomy. Okay, they are all teeth with deep carious lesions, signs and symptoms of irreversible pulpitis. The tooth is, however, restorable. There is no abnormal tooth mobility, clinical swelling. There is no pus exudate. There is no fistula. There is no early, the presence of early periapical changes like a widened PDL is fine. That is not a problem. But there should be no radiolucency at the periapical region. There should be no focal involvement. Okay, and of course there should be no calcification, no pulp obliteration, or internal external resorption, obviously. So this is the last case I'll quickly share with you. Bright red color, amount of blood overflowing from the pulp exposure site can be controlled within 10 minutes. These are the prerequisites. Use 2.5% sodium hypochlorite up to 10 ml, good hemostasis. Okay, a good coronal seal. Yeah, this was one of the cases in my book that was on 1-year follow-up. You can see the root is further matured, and that was on 2-year follow-up. You can see the distal root is of course slightly cut, but you can see the root maturation, but the mesial roots are very, very evident. So you do not want to subject a child to a full pulpectomy in an immature permanent tooth when success rates are so poor in these situations. Yeah, these are very difficult procedures to do, especially in young permanent teeth. They are very, very demanding in young children, and you have poorer success outcomes. So why would you subject a child to a full pulpectomy when we have better options that are available? Do look at this article, and that's why I just mentioned it very, very quickly here. The Endolyte Concept, Walters et al., where he says you shouldn't use the word irreversible pulpitis at all. Start using initial, mild, moderate, and severe pulpitis, but don't call it irreversible because there is some amount of vitality left in that tooth. Look at this situation where I did a pulpotomy in this tooth again, and look at the lovely root maturation. This again was almost like a miracle. In 2008, it looked like there's no tooth structure left there. And most often this tooth would have been condemned to an extraction. And just look at how beautifully this tooth matured in the long term, right? And you have lovely root development there. And we have saved this root completely. So these are the advantages of a biologically driven treatment procedure. I think I'm completely out of time. So look out, remember in this to look out for follow-up. This is my last slide, Dr. Faisal. I was told 1 hour. I'm really sorry. So I, had timed this for a whole hour. But, some teeth may get silently necrosed, rarely. So please look out for that and keep these patients on long-term follow-up. But remember, if your vital pulp therapy fails, you can always go back and do a root canal treatment. It doesn't stop you from doing root canal treatment. So remember, you can go back and do root canal treatment there. But what you're doing here is literally saving tooth tissue and watching it grow. So remember, in the anteriors, the time, the size, and the kind of bleeding. In the posteriors, remember indirect pulp cap, selective removal of pulp tissue, and vital pulp therapy. These are great choices because the choice that we make is left to you and me as clinicians, and a good choice we make for that child patient today will lead to a better tomorrow for that child. You and I have the power to choose. We must choose very, very wisely, and our child patients and their parents will completely love us for it. I have always lived by what I call my child principle. Do for my patient what I would have done for my own son. I've always lived by it, and I would suggest that that is the best way we as pediatric dentists or we as dentists treating children should practice the my child principle. Do for our patients what we would have done for our own child or our own niece, our own nephew, our own family member. Thank you very, very much for your attention. It was a pleasure.
Thank you very much, Dr. Meenakshi Kher, for this wonderful and very informative presentation. Actually, it lasts for 1 hour, but it looks it just passed very fast. We do not realize the time. It is very interesting lecture, and really we are facing these cases every day in our practice.
Correct.
So better to know that we still have a golden option has to be tried before going to deeper invasive procedure. So I will open now the question. Please, if anyone has a question for Dr. Meenakshi, can you please write it down in chat box? And also, I want to remind you that all this scientific event is recorded and will be uploaded in our website and also on our YouTube channel. Also, SME hours for this lecture going to be credited for members only. To register in Saudi Society of Dentistry, you will find the link there. You can just follow the links and follow the instruction to for subscription. Now, any question from audience for Dr. Meenakshi, please. Let's have it.
Sorry?
Yeah, while they are preparing the question, I have a question for you, Dr. Meenakshi. In terms of long-term prognosis, do you notice any differences between biodentin and conventional MTA? I know the discoloration drawback of MTA. It is a real factor. But how about the success rate among this both material, MTA and biodentin? Have you noticed any difference in success?
Not really. I haven't. I have found both of them equally successful. Both MTA and biodentin, I found them equally successful. No, I haven't seen any difference in the success rates, though I must say I'm a clinician. I haven't conducted a study that is, a proper randomized control trial where you compare both. I haven't done that. But no, I haven't in my clinical experience seen any difference in success rates. But the discoloration, see, at the end of the day, I realized earlier when we used MTA, the follow-up radiograph, we got the patient in, you took a follow-up radiograph, you saw the root development, and we were so excited, me and my associates, wow. And, to the patient, it doesn't make a difference. They are free of pain. They have a healthy tooth in the mouth. There is no pain. The gums are fine, and the tooth is fine. So, for you and me, it's a big success to see that root grow. We may show it to the patient and say, hey, look, your tooth was like this. Now it's growing. It's become big. But it's you and me who are excited. To the patient, it's nothing. Their mouth is fine. So if you give the patient a discolored tooth, that's a failure for the patient. It's a complete failure. They don't care that the root grew. They don't care the root matured. They don't care longevity. If I've got a black tooth today, I don't care that I'm going to have a tooth 10 years from now. I'll say, no, give me a white tooth today. So I realized that the discoloration that MTA gives is just, far more challenging to mask later. But to answer your question, success-wise, I haven't seen a difference. But with all these situations with the pulp, your technique has to be spot on. The rubber dam in, quick work, and very clean and neat. We've got to be very particular, which we may not be with primary teeth. But here you really need to be in order to ensure success.
Exactly. We have a couple of questions. Actually, we cannot take them all. We will have additional 2 questions, then we will have to move to another lecture. This question from Dr. Iftikhar Ahmed. His question is, what is the percentage of success in irreversible bulbitis cases?
Great. in irreversible pulpitis cases in an immature permanent tooth, where we do a pulpotomy or we do an extended pulpotomy. And by the way, I always use MTA in the posteriors. I don't use biodentine. It's just a habit. And I love my MTA. I use MTA in all posteriors. Excellent success rate. Okay. And evidence shows, like I showed you that last paper, a lot of evidence shows almost 100% success rate. Like those two papers, the references I shared, I hope you saw that. So, and in my clinical experience, I've had great success rates. So what you need to do is extirpate or remove the coronal pulp until you see good bleeding that gets controlled within 10 minutes with 2.5% sodium hypochlorite. So get in up to the orifices. You can even go a little deeper, but you must be bleeding, and it must be, you must be able to control it in about 10 minutes, and you should be good.
Exactly. We have another question. I think it is just similar like the previous one, but it is taken from different aspects. In your experience, how many tooths end up with root canal treatment?
So long ago, many years ago, when I first started this procedure, I think I was not very good with being particular about technique, and I attribute it to that. So maybe about 15 years ago when I did it, there were 1 or 2 teeth I had to re-enter and do a full pulpectomy and root canal treatment, endodontic treatment. But in the last 10 years, I don't remember re-entering at all. I have done it in the past, but I would attribute it to not being very particular about my rubber dam, starting with the rubber dam, not being extremely particular, not being extremely particular with my sodium hypochlorite, and using calcium hydroxide at that time. I remember, not MTA. And I'm not saying you can't use calcium hydroxide, but of course, MTA calcium silicates are superior. I had used calcium hydroxide and I needed to re-enter, but not in the last decade, no.
Thank you, Dr. Meenakshi. On behalf of Saudi Society of Pediatric Dentistry, we thank you very much for this wonderful lecture, and we award you a certificate of appreciation for your contribution in our event. So we really enjoyed your lecture, and we hope that we have you so many times in future in our society, in our scientific activity. Yeah.
Thank you.
Thank you.
Bye. Bye. My pleasure.
Bye. Bye. Goodbye. Thank you very much.
Thank you.
Thank you for your audience, for your patience, and thank you for Dr. Eman Bakhurji, because we have taken some time from you, and we are sorry for that. But I think we still have plenty of time in your lecture. Again, SME members who are they are only ones who can get SME hours of this lecture, of this event. So please subscribe in society membership. And I want to give very brief introduction about Dr. Eman Abdel Jalil Bakhurji. Dr. Eman is a consultant and assistant professor, pediatric dentist that achieved diploma of American Board of Pediatric Dentistry 2013 and American Board of Public Health in 2018. And she got so many other certificates. She's very perseverance doctor. Actually, she very qualified in many specialty. She's working now as a full-time assistant professor in Imam Abdul Rahman Al Faisal University in Ad-Dammam in Preventive Dental Science Department. She contributed in many scientific events in national and international activities. Also, she post so many posters, and they have many contribution in scientific activities. Today, Dr. Eman will talk about LSTR, which is really open big question. What does it mean? What is the abbreviation of what? And how can be performed? And what is its indication? Also, Dr. Eman will discuss current practice and literature review regard LSTR. We are ready to know what does this term means from Dr. Eman. So please welcome Dr. Eman in our webinar, and you have the mic.
Good evening, everyone. Thank you so much for that brief introduction. That was very nice hearing about myself. Can you see my slides?
I can see your now I can see your slide.
Okay, perfect. Because I wanted to make sure that they're already shared. So I'm just gonna. I don't know how to see my slides only without looking at the camera. Hide the camera. Okay. All right. Thank you so much for having me tonight. Well, continuing on the theme that we're having this evening of talking about pulp therapy, we're moving now to talking about pulp therapy in primary molars instead of permanent teeth. I'm very delighted to introduce to you tonight the concept of LSTR. Well, actually, when the presentation was posted on the Pediatric Dentistry Society website, everybody went and I think tried to look it up if they were not familiar with the concept. And I intentionally wanted to make it a little bit mysterious so we can actually look at it tonight and talk about it a little bit more. All right, so the outline of tonight's presentation will be talking about what is LSTR, what is the evidence behind this technique, and what would be the recommendations for clinical practice. As we already know, everybody we face in our practice every day caries that is approaching the pulpal tissue. And traditionally, and as a standard of care, if this caries is reaching the pulp, and the tooth is vital, we do pulpotomy. And if the tooth is not vital, we do pulpectomy, and in some cases, we extract the tooth. But sometimes we face some challenges in the clinic where there's some physiological or pathological resorption of the roots, or we have to face internal resorption, whereas also there is no permanent molar that has already been erupted, so we can really extract the tooth. Also, some clinicians, they say, if you're not really well experienced, you could end up with over-instrumentation that could injure the developing permanent tooth bud. And although that we have to instrument and clean up the canal and shape them in case of pulpectomies, 40% of these canals may still have bacterial cultures. And basically, we already know that's because of most of the bacteria comes from the accessory canals in the truncation area. So this is where LSTR comes. LSTR. So what is LSTR that we've been fascinating about? LSTR is basically stands for lesion sterilization and tissue repair, whereas there's no instrumentation of the root canal is required, and instead you open the pulp chamber, you mix antibiotic, you place it in there, and you close it up. So the basic concept behind it is to not touch or do not remove and leave it as it is, and let the host defense mechanism take care of it, in addition to the antibacterial effect of the antibiotic that we've been placed. The history comes really from the 1990s, when Hoshino in the Cardiology Research Unit in Japan introduced this concept. After 8 years of that, Takushi popularized this technique, and he put some of his own modifications on it. So what are the indications of really doing this LSTR procedure? Of course, as we mentioned, you have a primary tooth with irreversible pulpitis, or the tooth is necrotic, comes with an abscess or sinus tract. There is radiolucency in the furcation area or some root resorption. The tooth could be painful or tender to percussion with not more than grade 2 mobility. The also could be a pulpous tooth in hemophilic patients, of course, and cooperative kids, which we face a lot in our clinic, and that could be a challenge sometimes for doing typical pulpectomy procedures. And the tooth has to be maintained for less than 12 months, and we're actually going to talk about this later with some evidence behind it. We cannot do this technique if the patient is allergic to antibiotics, such as penicillin or some other antibiotics that we're putting in the pulp locally. If we have excessive internal external root resorption, or the tooth is about to exfoliate with a grade 3 mobility. If we have a perforated pulpal floor, excessive bone loss in the furcation area involving the underlying developing tooth. If the tooth is non-restorable, well, in some cases, you might even do it in some non-restorable teeth just to maintain the tooth for a little bit as a space maintainer in that area for some time. And of course, you cannot do this in infective endocarditis children or patients with immunocompromised. So what is the antibiotic mix that we have to put we have to mix and prepare and put it in the pulp? Well, traditionally, it is minocycline, Metro, and Cipro. Hoshino, when he introduced this technique, he had a 1:1:1 ratio of all of them together, but Koshij, he put them in a 1:3:3 ratio. And they usually combine it with propylene glycol and macrogol, or sometimes they call it propylethylene glycol. But of course, minocycline is a tetracycline-like drug, which causes staining, and we're going to talk about it a little bit. So it is not really encouraged to use it, especially if we are using tetracycline and minocycline as well as part of it. This technique and this mixture of antibiotic has been effective against Endococcus faecalis and gingivalis. And the faecalis one is the one that is present in the interradicular area and causing all of the bone resorption and endodontic infections. So this mixture is actually effective against these. So the triple mix, how does it work? The Metro acts as against gram-negative and positive anaerobes, while the Cipro facilitates destruction of gram-negative organisms, and the Mino is a broad-spectrum antibiotic that works against gram-negative and positive and spirochetes. And you mix them in a 1:1:1 ratio. So how can we prepare this antibiotic paste? Well, actually, you're not going to find it in your clinic. It's not really sitting in the drawer of your clinic. This is something that you have to purchase and prescribe for yourself from the pharmacy. So you come up with the pills. You prescribe the pills, and you have the antibiotic pills where you put each one of them in a separate dipping dish and try to crush them. Before you crush them, you have to scrape the outer surface of each pill to remove the coating. And sometimes if it comes in a capsule, in a soft gel capsule, you have to open the capsule and remove the coating from it. And then each antibiotic is powdered separately in a clean mortar and pestle, and then you take a mixture, a little bit, mix them on a glass slab or a mixing pad with equal parts with the solvent, which is the propylene glycol. The best mixture, they say, is the rate of a ratio of 7:1, which is 7 parts of each antibiotic to 1 of the solvent. And then until you mix it in a coherent, very soft mixture of a ball in like a small diameter, like a 1 millimeter diameter. In a patient, you actually give a local anesthesia, you put your rubber dam on. Well, sometimes if the tooth is necrotic and patient is not willing to take the local anesthesia, you might not do the local because the tooth is necrotic and you're not really gonna touch much of the pulpal tissue. And then when you open the, you remove the caries. Well, you have to remove all of the caries walls in there. There was a study that they mentioned that they looked at not removing caries from the wall, and they ended up with failure, with a lot of failure with the LSTR. So you have to remove all of the caries from there. Sometimes if you have a canal that is not really necrotic, you might clean it up if you could and file it a little bit, but it's not really necessary. And then you might irrigate with sodium hypochlorite 2.5%. In that way, the tooth is almost ready to receive the antibiotic, but you might need to enlarge a little bit the orifices of the canals to make it to receive the medication better in that area and make it penetrate a little bit better. And sometimes they say that the APD says you might need to apply phosphoric acid on the walls, which is I might be a little bit careful with, because with phosphoric acid is an acid, and I would be very careful in applying it, especially in the provocation area where there are a lot of accessory canals that might penetrate into that area. Some others, they say you might prepare the area with editor to make it more to make the medications penetrate better. After that, you have your mix ready. You put it in the pulpal tissue, and after that, you just seal it with GIC cement and restore the tooth with a stainless steel crown. Here's the case where the patient came with an abscess tooth, a gingival abscess. Of course, the tooth was cleaned and the antibiotic was placed. And this is after 12 months with stainless steel crown, where all of the infection have been gone and no signs and symptoms. This is another case that's been shared with me from Dr. Muhammad Hassan. The patient was like around 7 years old, was not cooperative, came with a large abscess related to tooth I. This is there is a double antibiotic was placed of Metro and Cipro. We're going to talk about the different techniques and different antibiotic mixes. And this is after 2 weeks that we can see the abscess has went down really a lot. This is a 3 months follow-up. Well, the infection or the abscess has already been gone completely. I apologize for this latest picture, because we asked the patient to send us his picture from home, because he didn't come for show the 3 months follow-up, so the picture quality is not that great. This is another case where you can see the abscess here related to tooth B, and Cipro and Metro were placed as an antibiotic when the tooth was covered with stainless steel crown, and this is a 3 months follow-up where you can see the abscess has completely gone. Of course, the gingiva is a little rolled here because of, you can appreciate here the bad oral hygiene that the patient is not really cleaning well, but the abscess has completely gone. This is another case that has been shared with Dr. Simchi from his practice, where he did the triple mix of Clenda, Metro, and Cipro, and he put it in the pulp, and he followed up the case. This is like about 4 months after, and you can see and appreciate complete bone healing in the area. This is one of another one of his cases where you can appreciate here that the permanent tooth has not erupted yet. So he had to do something about this tooth instead of extraction. He did the LSTR, covered the tooth with stainless steel crown, and followed up the case for about 2 years. And you can see complete healing here, and the tooth is well, no signs and symptoms. So what are the advantages of doing LSTR? It's easy, of course, and simple. You don't have to instrument. You don't have to do any obturation. Treatment time is short, economical, because you're not gonna put MTA or Vitafix there, which is a very expensive material. It is painless, especially if the patient has a pulpless tooth, necrotic, is not feeling anything, is not willing to take the local anesthesia. No instrumentation is needed, no obturation, as I said. And the material is kind of non-irritant to the periapical tissue. Well, it depends, and that has to be decided as well. There is no need to use formicrysol. Well, actually, yeah, if you compare this to pulpotomy cases where people are afraid of using formicrysol and the toxicity that comes out of it. The disadvantages of using this technique is using the minocycline in the mixture, which could cause discoloration effect, because the calcium ions in the calcium ions binds with the drug, and it's called bichylation, and it causes discoloration of the tooth. So we're going to talk about this in a bit, how to avoid this discoloration altogether. The original mixture of antibiotic is radiolucent, but we're going to talk about how to make it a little radiopaque if we need to. The antibiotic reaction and the bacterial resistant is something that we should be always thinking about, is not to develop resistant strains of the bacteria, and that could be overcome by using not only one medication or one antibiotic. It has to be a mix of different types of antibiotics from different families to fight together in the for the anaerobic bacteria, gram-positive and negative, and all of them. The developmental anomalies to permanent teeth, well, that is something has not been studied well in the literature. Nobody knows until now, and nobody followed up the cases for long enough to figure out if there is any developmental anomalies could be caused by the triple antibiotic mix that placed in the pulp chamber in there. The hollow tube effect, well, basically the hollow tube effect is because we are not really filling the canals with any intracanal medicament or filling material or obturation material. And the worry is that these canals, empty canals, will be invaded with bacteria later on the long run. And so far, nobody have studied this or found out about it or followed up the cases long enough. So what are the factors that could influence the action of the triple mix? Well, first, you have to have a good quantity of the mix placed in the pulp chamber, where it covers all of the pulp chamber and it covers all of the orifices of the canals. You have to use more than one antibiotic, as we said, because we don't want to have resistance to the mixture or to the antibiotic we're having from the bacteria, or develop resistant strains. The antibiotic should produce least damage to the host cells and should not cause any sensitivity. And we might need to remove the smear layer with editor to enhance the penetration of the medication in there. So what is the evidence behind the LSTR? Well, I divided the evidence behind LSTR into 3 categories. evidence related to the antibiotic mix itself, evidence related to the mixing vehicle, and evidence related to the procedure itself. So let's start with the antibiotic mix. As we said, and we mentioned that minocycline is a tetracycline-like antibiotic, and it could cause discoloration of the tooth, and that's why there have been some other studies and alternatives for that, like clindamycin or cefaclor, and it's been working very well in these studies. Some other, like Benched and Troop, they actually said we could add a bonding agent in the pulpal floor before the antibiotic mix, after the antibiotic mix, or flowable composite to cover it, so that will prevent or minimize the discoloration. Personally, I would try to avoid minocycline altogether and any tetracycline-like drug, and I might go with clindamycin or maybe with a double antibiotic. So the double antibiotic, instead of putting three types of antibiotics in there, we could switch it with two types of antibiotics, and it's been effective against Endococcus cephалus and gingivalis, which we've talked about previously. And these double antibiotics could be the clindamycin with cefaclor, or we could use the Cipro with the Moderator for deeper penetration into the dentinal tubules. And also we mentioned that this antibiotic mix is radiolucent in radiographs, so we might need to add iodoform to make it radio-opaque if we would like to. There have been many studies looking at different concoctions and mixtures of antibiotics. I'm going to mention the most prominent ones in this lecture, where there's a guy in 2013 looked at two different mixtures, Cipro, Mino, Metro, versus the Cipro, Mino, and tinidazole. Tinidazole is a second generation of the metronidazole, but it is more effective and have less side effects. And they followed up the cases for 2 years, and they found no radiographic difference in the success rate between these two mixtures of antibiotics. Another studies, they looked at the two mixtures of antibiotics. One of them is the traditional minocycline in them, and the other one is the clindamycin, and they followed up the cases for a year, and they found no radiographic difference in the success between these two different concoctions of medications, which makes us really happy that we might need to avoid the minocycline altogether. So when we come to the evidence related to the vehicle of mixing, which we talked about the propylene glycol and macrobol, Takushi in the 1998, he compared this to the endodontic sealer, and he found still the propylene glycol is better for deeper penetration. While Pinky and Nananda, they only worked with the propylene glycol, and for maximum bacterial inhibition, the chlorhexidine 2% could be recommended, of course, versus distilled water. If you compared anything that is antibacterial to distilled water, you will have better success. When it comes to the procedure itself, what should we do? What should we choose? Is it better to do pulpectomy, or is it better to do LSTR? So let's see what is the evidence or the literature say about LSTR. One of the papers that I've looked at, which is very recent paper that looked at 3 different techniques for doing LSTR. They didn't really compare it with pulpectomy in the study. They just looked at different ways of doing LSTR. The first technique is to do the ordinazole, Cipro, and cefaclor either without removal of radicular pulp or with removal of the radicular pulp, and compared it to the chloramphenicol, tetracycline, and zinc oxygenol paste. Of course, the first mixture of antibiotic with removal of radicular pulp gave the best results radiographically and clinically, followed by the same mixture but without removing the radicular pulp, and the least success was with the tetracycline and chloramphenicol and zinc oxygenol paste. How about if we look at the LSTR versus pulpectomy, because that's what we're going to actually face every day in the clinic. Should I do pulpectomy or should I do LSTR? Should I come up with out of this lecture to saying that I'm going to do LSTR all the way, or should I be cautious about it? So I'm looking at here different systematic reviews where they compared LSTR to Vitapex pulpectomy, and they followed up the cases for a year, and they found no difference between the two procedures, and the quality of evidence that they found in this systematic review was fairly good. But Duarte compared in his systematic review of pulpectomy to LSTR up to 18 months, and also found no difference between the two procedures, but he deemed the quality of evidence to be low to moderate. When it comes to the AAPD guidelines, they all come from Cole et al. Systematic review, which talked about non-vital pulp therapy. I just extract the portion of the evidence that is related to the LSTR. Well, they followed up in their systematic review. They looked up at 12 months follow-up with meta-analysis. They found out this: if you have a tooth with preoperative root resorption, okay, without preoperative root resorption, pulpectomy has better success than LSTR, but they didn't find any significant difference between these two procedures, and the quality of evidence was low. But on the other hand, if you have a tooth with a significant root resorption, like more than 1 millimeter or internal root resorption, LSTR becomes better here and performs better than pulpectomy with a moderate quality of evidence. Qualitative research looked at 24 months of success for LSTR to be like a little bit low, like 37%, but there is like only one study that looked at longer duration of follow-up for LSTR versus pulpectomy, and in that study, they actually had very interesting results. They found out that with LSTR, you have a faster root resorption, but you have also more intraradicular bone loss and delayed eruption of the permanent tooth, which I find a little bit contradicting, because once you have bone resorption, you might expect actually accelerated tooth eruption. So I think the evidence here, with looking at all of the literature present, we might need to take the evidence with a grain of salt. Choosing pulpectomy versus LSTR, it might be really promising to do LSTR, and I think there is a lot of potential into this technique. Although we don't know much about it till now, we have a lot of literature about it, but all of the literature, they didn't really mention a lot about the preoperative condition of the tooth itself, except the systematic review done by Cole, where they looked at the root resorption, but there are some other factors that we might need to look at. But just say you have a patient in the clinic and you selected the case and you wanted to try doing LSTR in this patient. How can we make this technique practical for you in the clinic? Well, actually, this is what I do. First, you will have to prescribe the antibiotic for yourself, as if your patient, or for your patient, and get that from the pharmacy. Get Cipro, get Metro, And you could get clindamycin if you would like, but I would do just the double antibiotic. You take 1 pill of each separately. You scrape the pill coating from the outer surface and try to crush them. طبعا we don't maybe have a mortar and pestle in the clinic. You might use amalgam, Dayton dish, and the large condenser to crush the pill, or maybe the back of the large spatula. After that, you might not have propylene glycol. I might use it, mix it with local anesthesia. It is a sterile solution which works beautifully to mix that, or you might use the liquid that comes with the MTA if you have some. For the patient, you might do your anesthesia if the patient is not, if the tooth is pulpless, necrotic, patient is not feeling it, so you might do it without. If the patient is not cooperative, try to open the tooth, remove all of the pulpal tissue, irrigate all of the caries. If you have any remaining pulpal tissue, you might need to remove it from the canals if you could, and then irrigate with sodium hypochlorite. Enlarge the orifices if you can, and then put the mixture, cover it with glass ionomer and stainless steel crown. So at the end of this presentation, I'm looking at all of the evidence of LSTR, and personally, I feel it sounds very promising, and we've had some success of clinical cases that we've done in the clinic, but we have to be very cautious with this technique. So far, we don't really know what is the permanent or long-term effect of putting any antibiotic in that area on the developing permanent tooth. There are not a lot of long-term studies on it. Also, the factors influencing the tooth-related factors influencing the choice of treatment of LSTR versus pulpectomy have not been studied yet. They always come up with, all of the literature come up with two teeth similar, pulpless or necrotic. But what about if we compare a tooth with large abscess versus a tooth that has just only hyperemic, for example? So does the size of the lesion differ? What if we have a facial swelling in there? I think we need longer duration follow-ups for this technique. And if we can be very selective in choosing this technique, we should choose it when we have a lot of follow-ups, and if the tooth, we want to maintain it a little bit temporary, or the patient is very uncooperative, and that would be the end story with us. We cannot really do pulpectomy, we cannot extract in this patient, and we might get some cooperation for just opening the tooth and placing the antibiotic. So we should, I would think of just giving it a chance. So that would be it for my presentation. I would like to thank at the end the Saudi Society of Pediatric Dentistry for this opportunity to have me tonight talking about this interesting topic. I would also like to thank Dr. Muhammad Hassan from King Faisal University in Al-Hassa for sharing some of his cases, and also to Dr. Rayal Simchi from the Riverfront Pediatric Dentistry in the US for sharing his experience of his cases with me. I've seen like a lot of pediatric dentists in the US starting to embracing this technique in their practice. We can say that they have a lot of success, to be honest. We can say there might be, we consider them as case reports. We still need to do some more in that area where we can actually look at the longer duration follow-up and follow up the cases very closely. Thank you so much.
Thank you, Dr. Eman. We really enjoyed your lecture. Actually, this promising material worth a try, as would most of we cannot say most. I mean, some of the child in the clinic comes with pain, with infection sometimes, and also uncooperative. So might be this is a good quick solution. You can try and observe the outcome.
Definitely. Actually, this technique is like sometimes becomes as a savior in the clinic where you don't have any other option but just to do it in a patient with necrotic tooth, very uncooperative. You cannot do anything else for the patient at the moment. So I think it's worth trying where you really need it.
Exactly. Now we open the time for question from audience. Actually, I received so many questions till now. I will start. Reading it one by one. Is the premix antibiotic available commercially to avoid any technical error in mixing?
To be honest, I'm not really sure if we have any commercially available here, at least in Saudi Arabia. We don't really have it. I am not sure or not. I'm not aware of there is anything available in the US at the moment. But I think if you follow the technique that I've described, it works well. It's not really very technique sensitive, I need to say the truth. It's not really technique sensitive.
Yeah. The second question is there any differences in success between first and second primary molars?
I didn't see anything about comparison between first and second primary molars. Well, I assume in first primary molars, you have more accessory canals in there. But I don't really know for sure if there is any better success in second primary molar versus the first. And in my opinion, which is not really based on evidence, in my opinion, I would always try to save the second primary molar than the first primary. But if you don't really have the option, you just really go for it. Because what is the worst case scenario that you could end up with? You try it, you might not, it didn't work for you, and patient comes back, you might just need to extract. And you have to explain this to the parent to begin with. You cannot really, you have to put all of the options and all of the scenarios in front of the parent, and they have to choose what they want. But I haven't seen anything in the literature as a comparison between these two teeth. But anecdotally, I would assume more failure in the first primary. But still, we cannot really conclude that.
Yeah. Do you remove the coronal pulp like doing pulpotomy, or just open the access and place the triple mix in it?
Well, actually, you are talking about a pulpless tooth, a necrotic tooth. If you have a tooth that is vital, when you open the pulp, there is pulp tissue and vital, you should not do this technique at all. You should do a regular pulpotomy. But I'm talking about pulpless tooth, necrotic. When you open the pulp, there is, necrotic pulp. You assume that you're not going to find anything in there. Only sometimes you have partial necrotic tooth canals, where some canals, maybe sometimes the distal canals, have some bleeding in it, where you can instrument it and take it out and irrigate with sodium hypochlorite. But you'll never open a pulp and open a tooth and you see like huge pulpal tissue, coronal pulpal tissue, and attempt LSTR. You don't do it with those cases. You do regular pulpotomy.
Yeah. After sodium hypochlorite, is it better to irrigate with saline or not?
You could if you want to, yes.
Thank you, doctor, for this informative lecture. I have a question regarding the root length. How much of the root should remain after external resorption, so still be considered for LSTR procedure?
Well, that's a very nice question. Well, in the APD they mention about internal and external root resorption, where is it like a little bit more than 1 millimeter. But if you have a tooth that have extensive root resorption, where you have like grade 3 mobility, and you can say the tooth has very minimal roots and about to exfoliate, or there's extensive damage to the radicular area, then the extraction would be better in that case. You would not attempt this with very extensive root resorption.
Yeah. What is your opinion regard using another material in same technique? For example, sodium hypochlorite.
I couldn't get it. What do you mean?
Yeah, I think the audience, he is asking that if you did not do this triple mix, you just irrigate with sodium hypochlorite and maybe just fill the tooth and
oh, okay. Well, I've heard about this technique from some people, that where they open the necrotic pulp, or sometimes even for pulpotomy, where they just irrigate and they close it down, and that would be it, with no intracanal medicament. I'd be cautious with doing something like this without evidence, because the reason of doing LSTR is putting antibiotic mix in there that would work with the host response in finding the bacteria in there and really make it like work for a longer time. Maybe you will have, I'm not sure if there is any success with that technique where you just irrigate and close. LSTR is not about that at all. You'll have to put some antibiotic, and it has to be more than one antibiotic potent to make sure that you're really disinfecting the area with the antibiotic, and without developing any bacterial sensitivity. Hello? Hello?
دكتور فيصل، دكتور فيصل ما بنسمعك، راح الصوت. تمام الآن.
الو، تسمعوني الان؟
الو، ايوه تفضل.
صوتي واضح؟ بسم الله، بعيد من جديد. Thank you, Dr. Eman Bakhurji, for accepting our invitation and being with us today. Actually, the both interesting lectures is available in our website, and also will be uploaded soon in our YouTube channel. And I encourage everybody, especially pediatric dentists and all the interested dentists, to subscribe in Saudi Society Pediatric Dentistry to have all this scientific events and get benefit from that. Also, I would thank again Dr. Eman Bakhurji for her contribution, and I award her a certificate on behalf of Saudi Society of Pediatric Dentistry, certificate of appreciation. Thank you, Dr. Eman, and thank you for your presence. And I wish you to see you again and again in so many events. الو، تسمعوني؟
ايوه دكتور فيصل نسمعك، بس اتوقع
ايوه
خلاص الناس تفضل.
ايوه انا بس احب اقدم الشكر والسيرتيفيكيت للدكتوره، واشكر الجميع على I thank everybody, all the audience for presenting our lecture, our activities today, and inshallah we will see you in subsequent scientific activity inshallah in future, and have a nice day.